This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of video or materials may be undertaken only with prior written consent of the AARC. Copyright 2010. All rights reserved. My name is Bill Dubbs. I am the AARC Director of Education and Management Services, and I welcome you to today's webcast on improving control of asthma symptoms. This program is sponsored in part by an unrestricted educational grant from Monahan. Reagan Hickey will take a few minutes to familiarize you with our sponsor. Reagan?
Thank you, Bill. It's estimated 12 to 15 million Americans suffer from asthma and upwards of 30 million having diagnosed and undiagnosed COPD. Therefore, it's crucial to be able to provide the most advanced medical devices to treat asthma and COPD. Monahan assures you the most cutting-edge methods are used to design, develop, and manufacture the aero chamber valve holding chamber product lines. The Monahan brand aero chamber has been the #1 leading valve holding chamber since its inception in the 1980s. Monahan is dedicated to developing new and exciting aerosol delivery devices to continually improve respiratory care and asthma management. The AeroChamber Plus FlowView is a revolutionary valve holding chamber created to virtually take all the guesswork out of aerosol delivery. The only chamber with the FlowView indicator, Monahan is enabling providers for the first time to be confident of proper inhalation during inspiratory maneuver. With their state-of-the-art aerosol research laboratory, Monahan has worked diligently with the best scientists, doctors, and respiratory therapists in the world to research and develop their newest line of anti-static valve holding chamber, the AeroChamber Plus FlowView AV-HC. As a leader in the manufacture and sale of aerosol drug delivery devices and asthma management products, Monahan is dedicated to the advancement of respiratory care and its professionals. A corporate sponsor of the AARC and a 7-time recipient of the Zenith Award, Monahan continues to lead the medical science behind aerosol delivery.
Upon completion of this AARC webcast, participants will be able to identify factors that affect asthma control, review key aspects of the latest expert panel report, the EPR3 Guidelines for Asthma Control, cite commonly used asthma control medications, and describe how respiratory therapists can improve asthma control in their patients. I am pleased to introduce Dr. Robert Cohn. He is a board-certified pediatric pulmonologist who was chairman, Department of Pediatrics, and associate medical officer for medical operations at Metro Health Medical Center in Cleveland, Ohio. He attained the rank of professor of pediatrics at Case Western University School of Medicine in Cleveland. Dr. Cohn earned a medical degree cum laude from Boston University School of Medicine and completed a pediatric residency and a pediatric pulmonology fellowship at Rainbow Babies and Children's Hospital and Case Western Reserve affiliated hospitals in Cleveland. He recently received his MBA from the Kellogg School of Management and Northwestern University. He received grant support for research on asthma, cystic fibrosis, and other respiratory subjects. Dr. Cohn has been honored by a number of organizations throughout his career. He was recently inducted into the American Pediatric Society and also was appointed as a fellow of the American Association for Respiratory Care. He has been repeatedly recognized for teaching excellence. Dr. Cohn discloses that he has been on the Speakers Bureau of and received grant funding from Novartis, Genentech, AstraZeneca, Merck, GlaxoSmithKline, and Sepulcor. He has also received compensation for speaking and consulting work for the AARC. Bob, welcome to the program.
As Bill mentioned, I'm a pediatric pulmonologist, and I had the pleasure of basically developing a pediatric asthma compliance and technique clinic with the respiratory therapy department at Metro Health Medical Center. And so what I want to do is review some of the information we learned from that technique clinic, as well as go through the asthma new guidelines. As everyone knows, asthma is a lung disease characterized by three things: airway obstruction, which is at least partially reversible, hyperreactivity, which is due to increased bronchial responsiveness to a variety of stimuli, and inflammation. The inflammation tends to be eosinophilic inflammation in asthma, although neutrophils can be seen in certain types of asthma. So if you were to do a bronchoalveolar lavage, those were the kinds of cells you would see. Alveolar macrophages are normal under normal conditions. When you do a BAL for normal individuals, you would not see eosinophils or neutrophils. Asthma is very prevalent. As many of you know, about 33 million people in this country have had the diagnosis of asthma in their lifetime. And of those 33 million, 22 million people have active asthma. Almost half suffer from asthma attacks. And the thing to bear in mind is that asthma is still a fatal disease. So approximately 11 people die per day. And of those 11 people who die per day, if you look annually, 150 are children. Childhood asthma affects about 5% of children in this country. It's the most common chronic illness of childhood. It's the most common diagnosis for admission to children's hospitals. And as you can see from this slide, it accounts for about 200,000 hospitalizations in this country per year and 13 million physician visits per year. And when you look at school absenteeism rates, the absenteeism rate for asthma is 3 times that of other illnesses. Now, one of the things that you need to be aware of as respiratory therapists is that physicians and others will throw around other terms which will cause an underdiagnosis of asthma in children. You've probably heard terms like reactive airway disease, recurrent bronchitis, wheezing bronchitis, recurrent respiratory infections in children. Bear in mind that any of these diagnoses is basically masking the diagnosis of asthma in children. Now, you should suspect asthma as a diagnosis if you see any of these things: a history of recurrent respiratory symptoms, symptoms that are made worse by certain triggers or allergens, symptoms that occur or worsen at night, and any evidence of reversible airflow limitation, either on pulmonary function testing or by clinical parameters. So if you were to give an albuterol aerosol to a patient and they got better, that might suggest reversible airflow limitation. Now, the signs and symptoms of asthma can sometimes be tricky. I mean, we're all aware of the fact that cough, wheezing, and shortness of breath are very common, but we've seen many children whose only sign or symptom of worsening asthma is fatigue or quietness. In addition, I've had a number of patients come to me and complain of a scratchy throat prior to an asthma exacerbation, or darkening circles around their eyes prior to an exacerbation. So bear in mind that there may be other things that present as asthma symptoms. Now, the NIH and the National Asthma Education Prevention Program first created guidelines to help us with managing asthma in 1991. It was their first attempt to include evidence-based recommendations and also to look at objective measures of lung function, look at how environmental control may help, and really recommend a stepwise pharmacologic approach to dealing with asthma treatment. It also emphasized certain aspects of patient education. Now, in 1997, the guidelines were updated so that the inflammatory basis of asthma was highlighted. And at that time, the guidelines talked about long-term controller medications and quick relief medications. People used to use the term reliever medications. They would use rescue medications for reliever medications as a terminology, or they would use preventative medication instead of controller medications. So in 1997, the switch was made to define these classes of medications clearly. In 2002, the NAEPP and the NIH updated certain selected topics, and so they put out their recommendations with regard to the use of inhaled corticosteroids in children, as well as combination therapy, and then made recommendations with regard to asthma monitoring prevention. The big thing about the 2002 guidelines is that they really wanted to promote the fact that inhaled corticosteroids used in the proper dosages were safe for children and were the first-line therapy for all aspects of persistent asthma. Now, the guidelines were updated in September 2007 by an expert panel report, which is called EPR3. And in this report, they focused on key differences from earlier recommendations. They define asthma severity different from asthma control and looked at responsiveness to treatment by definition. Severity is used when emphasizing the initiation of asthma treatment, impairment, and risk. By definition, severity refers to the intrinsic intensity of the disease process, and it's most easily and directly measured in patients not receiving long-term therapy. Now, the problem that I have, and as I'm sure you've been aware of, is most of the time we see patients for the first time who have already been put on certain asthma medications other than a short-acting beta agonist. So it may be hard to identify their immediate asthma severity off medications, because I don't think it would be ethical to take them off just to try to determine that. Control is the degree to which manifestations of asthma, particularly the symptoms, the functional impairment, and the risk towards bad events, are minimized and the goals of therapy met. Whereas responsiveness really refers to how easy is it to get asthma control when you begin or you adjust therapy. In the earlier guidelines, there were 5 of 6 goals of asthma therapy. Now there are several more defined by the EPR3 guidelines, but they're basically divided into 2 categories, reducing impairment and reducing risk. By reducing impairment, what we mean is that as goals of therapy, you want to prevent chronic and troublesome symptoms. You want to require very infrequent use of inhaled short-acting beta agonists. So, and one of the problems, I think, in pediatric practice, as many of you may have seen, is that many pediatricians will use albuterol on a regular, ongoing basis, as opposed to using it on a PRN basis. The guidelines really recommend it be used only as basically a reliever medication to give you some sense as to the degree of underlying inflammation and underlying lack of control. In addition, we want to maintain as near normal pulmonary function as possible, maintain near normal activity levels, and to sort of meet patients' and families' expectations of and satisfaction with asthma care. Now, in terms of goals of therapy for reducing risk, we want to prevent recurrent exacerbations, minimize the need for emergency department visits or hospitalizations, prevent the progressive loss of lung function, and provide optimal pharmacotherapy with minimal or no side effects. So as you can see, by reducing impairment and reducing risk, there are about 9 goals of therapy now. Now, the problem with asthma control is that there are so many possible things to measure asthma control, and they're not all interrelated, that it becomes very difficult clinically. So we can look at asthma control from a number of standpoints. Utilization of healthcare resources, what's the functional status of the patient, what are the daytime symptoms, Does the patient have nighttime awakenings? As I mentioned, how often are they using a short-acting beta agonist? What's the patient's self-report with regard to control? How much work or school is the patient or the family missing? And what about lung function as measured by objective means? Okay, now we have also the whole issue of measuring inflammation. And inflammation, airway inflammation, can be measured by a number of things, as many organizations have begun to use the exhaled fraction of nitric oxide as one measurement. In many centers, especially in earlier days, they would look at the sputum eosinophil counts, for example. So there are many, as you can see, there are many ways to measure asthma control, and they don't necessarily correlate with one another. Now, from our asthma clinic and from our asthma control clinic, we found that there are three influences on asthma control. There are the medication characteristics, there are patient variables, and there are physician factors. So, for example, with regard to medication characteristics, as we all know, medications are often used, but many times not used in children or adults for a variety of reasons. There may be issues with regard to the taste of the medications. Now, a taste of an inhaled steroid or an inhaled medication can work for you or against you. So let me give you a couple of examples. For example, there used to be a medication on the market called Arabid. Arabid, which is, I believe, flunisolide, tasted terrible. When patients started to take it, they would complain of its taste. So the company actually tried to create a mint-flavored inhaler, which was not very successful. That's an example of how medication taste can work against you. But on the other side of the coin is that patients want to be able to taste or feel their medication, because otherwise they don't get any kind of reinforcement that they're actually receiving a dose. So, for example, if you look at budesonide, the trade name is Pulmicort, and the Pulmicort Flexhaler or Turbohaler, you remember that the company used to pass out little purple handkerchiefs because patients didn't feel they were getting a dose when they used the Turbohaler. So the purple handkerchief was put over the mouthpiece, and so when someone inhaled on it, you could pull out and you could show the white powder on the purple handkerchief. This was the company's way to try to show people that they were getting medication. If you look at other medication characteristics, many of us know that the frequency and schedule of medications plays a role. So nowadays, most asthma medications are once a day or twice a day at most, because 3 to 4 times a day is just too often. The expense of medications is a key concern. In our clinic, we would hand out vouchers and samples routinely as part of the sessions because people are proud, especially in the inner city, and won't tell you that they don't necessarily have the money to fill a prescription. And what we wanted to be sure is that basically patients started to take the medications as soon as possible. Multiple doses and multiple medications can actually be a problem. I actually once saw a patient who was on 7 different asthma medications. This was a child, 5 different delivery systems. And as you can imagine, any one of us would have a hard time being fully adherent if we had to take 7 medications by 5 different means. Patient variables are also very important. So particularly, there's a misperception of attack severity or disease severity. This concept, which I've become very interested in, is called perception of dyspnea. And so you may see patients, and I've seen children, who basically will look like they're having trouble breathing, but when you see them and you talk to them and ask them how they feel, they will tell you they feel fine. For some reason, and this has been documented in the literature, their brain, the thermostat in their brain is not able to pick up difficulty in dyspnea. And so they end up having difficulty and really in getting into trouble when it's often too late. So for example, we've all probably seen case reports, I've heard stories of patients who were talking on the telephone and all of a sudden they keel over, or they've been playing on the football field during sports time and all of a sudden they have difficulties. These are major concerns with regard to the perception of attack severity and dyspnea. I mentioned the issue of failure to obtain medications and how we can get around that. Oftentimes, as you know, patients will stop medications due to unwanted side effects. Apathy is a big patient variable. I think one of the groups of patients where apathy may be a problem is in the adolescent population. But what we've discovered in our asthma clinic was that if you can tie in goals of therapy with what those individuals find important to them, then you'll be more successful. So it's apathy, but it's apathy towards what you're trying to teach them as opposed to what they're really interested in. There are certain beliefs and expectations in certain populations that you have to take into consideration and respect as well. In the older population of the elderly, for example, memory loss can also be a problem. Now, physician factors can relate to a lack of asthma control. As everyone knows, with the way healthcare is nowadays, physicians can't spend a lot of time with patients. So there's a tendency for poor communication, failure to monitor patients correctly. Patients may be given the incorrect medications or the incorrect dosages by physicians. And again, physicians may have a misconception of asthma severity. They may think the patient is feeling much better than the patient truly is. So when we look at factors complicating measures of control, there are many. And there are also a high degree of interpatient and intrapatient variability over time. So in a single patient, for example, they can have control and doing well during one part of the year, and then all of a sudden on the same medications, being as adherent as normal, they may have difficulty in a different time of the year. So assessment of asthma control cannot be based on a single time point or a single parameter. You have to look at many things. Pulmonary function testing is important here. The peak expiratory flow rate as a measurement is losing favor because, again, it's what some would consider an advanced topic of asthma control in those truly motivated. And it should not be used as a diagnostic parameter, but rather as a continuous monitoring parameter. One of the difficulties in using this is that, as you know, that patients will keep a diary. They'll bring the diary into their provider. And after a month of keeping track of numbers, the physician or the provider really won't do anything with those. So there is no positive gratification for doing daily peak expiratory flows. Beta agonist use, however, can be valuable if you have a sense as to how often your patient is using short-acting albuterol or the like. Now, I am a big believer in using spirometry in children. And in our asthma clinic, we could study children down to 4 years of age. And the EPR3 recommendations are very clear for spirometry. Spirometry should be performed, initial assessment, and after treatment is initiated and ongoing, so that if there's a change in treatment, spirometry is indicated, and it should be repeated every 1 to 2 years. I think we all are aware of the fact that there are countless children diagnosed with asthma on asthma medications, including inhaled corticosteroids, who have never had spirometry. Children who might be 8, 9, 10 years of age and older. It's really important to obtain baseline and ongoing spirometry in patients. And it may also be indicated more often depending upon clinical severity. One of the first studies that we did in our asthma clinic was to look at their clinical score versus their pulmonary function tests. And in the first group of patients, we found that in 50% of the time, the spirometry FEV1, or their peak flow measured on spirometry, was much worse than their clinical score. All these patients in these situations were on medications not strong enough for their given disease severity, and as such they were being undertreated by the guidelines. So I can't emphasize enough for you as respiratory therapists to recommend baseline spirometry in all children who are diagnosed with asthma. Now, the guidelines have four classifications for asthma severity. There's intermittent. The old guidelines called it mild intermittent, but it's now just intermittent because you can have a severe exacerbation even with just intermittent asthma. Mild persistent, moderate persistent, and severe persistent. Now, these classifications, again, are based on symptoms, so that intermittent symptoms are less than or equal to 2 times a week. But if you look at moderate persistent, it could be daily. Looking at nighttime awakenings, so less than or equal to 2 times a month for an intermittent individual, but anyone who is in the persistent category is having 3 or 4 nighttime awakenings per month. Looking at the short-acting beta agonist use, so really a patient should not be using it more than 2 times per week. Interference with normal activity, lung function is measured by FEV1 and FEV1 FVC %, and also exacerbations requiring oral steroids. That's how these are classified. And basically, again, the classification is used for the initiation of therapy. Now, when you're monitoring asthma after you've started a patient on therapy, there are many useful tools that have been standardized in the literature that are coming into vogue, particularly as it relates to clinical asthma control. And there are 3 that are currently used now: the Asthma Therapy Assessment Questionnaire, which is ATAC, the Asthma Control Test, and the Asthma Control Score. The asthma control test is the one that most people use nowadays. It's very easy to administer. It's 5 questions. You get a score based upon, in the past 4 weeks, you know, how much of the time has your asthma kept you from doing work or school. Basically, it asks for, during the past 4 weeks, how many times have you had shortness of breath? What about during the past 4 weeks asthma symptoms? What about in terms of using inhalers for short-acting beta agonists, etc. If you have a score of 20 and higher on the asthma control test, you're controlled. If you look at components of control, an individual who is well controlled has symptoms less than or equal to 2 times a day, has nighttime awakenings less than or equal to 2 times a month, is using per year at most. A person who is not well controlled or very poorly controlled, as you can see from this slide, is having symptoms much more frequently. The individual who's very poorly, they're extremely limited into their limitations. So as you can see, though, these are the same kinds of parameters that we're using to measure severity as we're using to measure asthma control. Now, let's turn to long-term control medications. These are used daily to achieve and maintain asthma control, and they include several groups. These are used as a long-term controller medication. Normally, it's used more as a reliever medication in short bursts, however. Cromolyn and sodium or nidocromil, a new class called immunomodulators, the leukotriene modifiers or the leukotriene receptor antagonists, the long-acting beta agonists, and the methylxanthines, the theophylline drugs. Now, I just want to point out that the new class of long-term controller medications called immunomodulators, on the market now is only one. Omalizumab is the generic name. The trade name is Xolair. The idea here is that this is a humanized monoclonal anti-IgE antibody, which is injected into patients to remove basically circulating IgE, which is the antibody that leads to allergies and inflammation. And so the idea here is that this is a new class of medications to modulate the immune system. As you can see, there are others in development, but none of those have really been used on a clinical basis. So if you look at specifically the stepwise approach for managing asthma, and you step up or down with daily medications based upon patient's response to these. In intermittent asthma, the only option is short-acting beta agonist or PRN. Now, I mentioned that there are 4 classes of severity: intermittent, mild persistent, moderate persistent, and severe persistent. In the old guidelines, there were 1 stepwise approach for each of those severity classifications. In the new guidelines, there are a total of 6 steps for the 4 classification. The treatment choices for mild persistent asthma, the preferred is low-dose inhaled corticosteroid, but the alternatives which are acceptable are cromolyn, a leukotriene receptor antagonist like montelukast or zafirlukast, nadocrimil, or theophylline. For moderate to severe persistent, it's the recommendation of the expert panel that there should be a consideration for consulting an asthma specialist. And this is true especially in children. So for step 3, you might consider a medium-dose inhaled corticosteroid or a low-dose inhaled corticosteroid with a long-acting beta agonist in combination therapy. Now, you may be aware that the Food and Drug Administration has put out a significant warning for long-acting beta agonists, which include salmeterol, which is Ceravent, and formoterol. And basically what they're saying is that they feel that the literature suggests that there have been increased deaths associated with long-acting beta agonist usage. So the recommendation is to really not use these except in combination therapy and with a specialist who is helping to manage the patients. Now for step 3, again, the alternative of a low-dose inhaled corticosteroid with a leukotriene receptor antagonist or theophylline or Xolutin, which is a leukotriene modifier, is an acceptable alternative. For step 4, which is more severe, they would recommend a medium-dose inhaled corticosteroid with a long-acting beta agonist, again in a combination drug. Although you can use as an alternative a medium-dose inhaled corticosteroid with a leukotriene receptor antagonist like montelukast or zafirlukast, theophylline, or Xolutin. For severe persistent, the preferred is a high-dose inhaled corticosteroid with a long-acting beta agonist. And consider, again, in those patients who have an allergic component to their disease and a high IgE level, omalizumab. Step 6 is a high-dose inhaled corticosteroid plus a long-acting beta agonist, plus the possibility of using every other day oral corticosteroids, and again, considering omalizumab in those patients with significant allergic manifestations. Now, the guidelines make very specific recommendations on allergy workups and immunotherapy, allergy shots. They should be considered for patients who have persistent asthma if there's a clear relationship between symptoms and allergen exposure. It's usually reserved for patients with year-round symptoms who are difficult to manage. Allergy testing, again, should be indicated for patients with persistent asthma at all levels. You can do this by allergy skin testing or measuring blood IgE levels, like a RAS test. There's recommendations, again, if they're at step 4 or higher, to consider an asthma specialist for consultation. Now, I want to just finish up by saying, as respiratory therapists, what tools can you use to rapidly determine whether or not you can help your patients improve their asthma control? And these tools, I use these as four legs of a chair. Think of always when you approach a patient, think of whether or not these 4 issues are being addressed. Has the patient obtained and received objective measurement of their lung function? Are they on the right pharmacologic therapy? Has there been effort to look at environmental control of allergies and irritants? Irritants being things like cigarette smoke, for example. And have they received the right patient education? Many asthma educators just want to flood patients with lots of materials, but you really want to use patient education in a very directed and focused way. So getting to the 4 components that may be useful for you is, again, has the patient received and had formal spirometry? We're not talking about just using peak flow meters, because again, pediatricians will prescribe peak flow meters, but they've never done baseline spirometry. And the difficulty is that patients' peak flow meter measurements, as you know, are effort dependent. And, you know, if you want to determine an asthma action plan using the right measurements, you want to be sure that you're not missing underlying significant disease. From a pharmacologic standpoint, really the two topics are, have you relieved obstruction, either with short-acting or long-acting beta agonists, and if necessary, using an anticholinergic medication, potentially as ipratropium, and have you treated the underlying asthma inflammation with the right dose and the proper medication, particularly inhaled corticosteroids. From an environmental control standpoint, many asthmatics respond to removal of allergens or irritants in their environment. I can give you two quick examples. I had a patient who was a child who sat at the front of the class that was using chalkboard, and we noticed that the child was having problems while in school, never had problems on the weekend. We then realized that the chalk dust was somehow affecting the child, and all we had to do was move the child to the back of the room, and their symptoms improved dramatically. The second issue, again, is I've had patients whose families, parents smoke cigarettes, as you all know, which can really affect children's breathing. And I had one patient in particular who was on chronic oral steroid medication, and I finally got the family, convinced them to stop smoking, at least around them, and to change their clothes and whenever they're around the child. That had a dramatic effect. So that's important. And then from a patient education standpoint, every asthmatic should have an action plan, particularly those with persistent asthma. It doesn't have to be updated at every single visit. It should be updated when the medication is adjusted. But it's really helpful if a patient has a problem in the middle of the night or is away and they have their action plan with them. It really helps the individuals with them or the emergency room or the hospital to know immediately what kind of medications they're on and how frequently. Are the goals of therapy being met? It's not good enough to start someone on a medication and not see them reasonably quickly. For us, the follow-up is usually 1 month, at most 6 weeks after a change in medication. And again, measuring their signs and symptoms by report, their lung function, their quality of life, etc. is important. I'm going to leave you with this and then open it up for questions. Always remember an approach to the difficult to manage patient. The first question is it asthma? In pediatrics and children, there are many diseases that asthma mimics. You know, all that wheezes is not asthma. I've seen children with anatomic lesions that went unrecognized. They may have gastroesophageal reflux or cystic fibrosis. They may have bronchiolitis during bronchiolitis season. The first question is, maybe it's not asthma. The second question, if you think it's asthma, is how is their adherence to the medical regimen, and are they using the technique of meter dose inhalers properly? Again, in the work that we've done and in many published studies in the literature, it's clear that many patients are given meter dose inhalers and they don't have to demonstrate its usage. In our asthma control clinic, we actually have the child administer it, and we actually grade them on the 8 or 9 steps each and every time they come in so that it's solidified. If there's a step not being done correctly, we can then review it with them to make sure they do it well. The third is, did they run out of medication and not realize it? This is important, again, with meter dose inhalers because, as you know, there's no easy way to measure unless you have a counter, you know, one of those meter counters directly in the system. You can't float a canister anymore. And it's oftentimes possible that there's propellant left in the inhaler, so when the patient activates it, they can see a stream, but there's no medication left. The fourth is continual exposure, particularly environmental. I mentioned the issue of the chalk dust in a child. Diet can be a problem as well. And the last thing, again, as I always recommend, even in my patients, if I'm not getting
Bob,
the right response, and I've gone through this checklist,
if you would turn off your
I have
microphone
no trouble
right now
getting a
just for
second opinion
I
from
want to thank
someone
you
else
for
to be sure that I've done everything.
That excellent overview of asthma at the beginning, very concise.
And so this is my last slide of the references for this talk, and I'm going to thank you for having me. I apologize for the initial
and I'm sure that the
technical
review
problem.
of the EPR3 recommendations and your ability to contrast those with the previous guidelines was very helpful to our therapists. Most importantly, though, your very practical advice on how to assess, monitor, and treat asthma, I think will serve all of our participants very well. We had a couple of questions come in, and for those of you that are that have questions, please put those up, type those in, and we'll get to them as we can. But I will start with a comment that was made by one of our participants, and I don't know if you need to react to this, but he noted that the EMS community, including paramedics and EMTs, has been taught these new guidelines, and treatment begins in the field, yet they're not cognizant on how to treat asthma cases. I guess just expressing a little frustration. Is there anything you'd like to comment about that?
Yeah, I think that clearly, I think when you're in the field and you're trying to treat an asthmatic who's having an asthma exacerbation, the medications that are going to be most valuable to you are albuterol. And again, initially, you're going to want to use, especially in children, a higher dose. So 0.5 cc's. Again, if you're monitoring them, doing it every 10 to 15 minutes in the field, or even sooner if necessary. Making sure that they immediately get a burst of high dose, either oral corticosteroids or intravenous solumedrol. That would be critical, because the sooner you start that, the better off they will be down the road. And if necessary, you can also go and use an anticholinergic agent such as ipratropium in the field. Those three medications, I think, in the field are the most important. And you push them, at least in children, to either an effect or until you start seeing severe tachycardia, desaturations, or what have you.
Thank you, Bob. Another participant wants to know about what you think of the role of vitamin D in asthma. And he also asked a question about radiofrequency heated bronchoplasty. Could you offer some comment on that, please?
Yes, they're great questions. There have been a number of reports in the literature showing children and others, particularly in the inner city, having low vitamin D levels. I think that's interesting. I don't think it's a treatment for asthma, but again, of course, you want your patients to be taking the right amount of calcium and vitamin D. In terms of the radioablation, I think, again, it has potential for a select group of significant patients. Because it's an invasive process, again, I don't think it's received mainstream thought at this point. It's certainly not a part of the guidelines, but there's been some interesting studies done with that.
Another person wants to know, what predicted normals are you using for your PFTs in children?
We use the Snowbird criteria, and basically those are the ones we've always used. Again, as you know, there are racial differences, there are gender differences, and there are also size differences. And anything more specific than that, I would have to defer to my colleagues who are certified in PFTs. Okay.
Now I'm working off of the actual list here on the screen in the participant window, and let's see. Here's a question. What is the most effective way to supply those that are unable to afford medicine?
Well, I think and again, it depends on which environment you're in. But I think using samples that are donated by the drug companies is the easiest and most direct ways. It's harder and harder to do that now for compliance, Joint Commission compliance reasons. So now, oftentimes, we'll have to go to a voucher system where many of the companies will give us a voucher instead of a sample to use in those patients.
Okay. And one person writes in, we have a huge problem with spacers in the school. Most kids will get their albuterol but don't take spacers. What's the best solution?
Well, that's a great question. And what we determined in our clinic was to teach children meter dose inhaler technique without the spacer. The spacer And the reason for that was very practical, because most kids won't carry their spacer with them. And so, obviously using it with an inhaled corticosteroid might be important to prevent oral candidiasis. But I think studies have shown that if you do the technique right, without a spacer, you get the same medication delivery than with a spacer. Now, in a very small child, obviously, who's not coordinated, a spacer or a spacer with a mask is important. But what we went to was, in those children who are old enough to learn the technique, we taught them without the spacer because we felt that would be more practical.
Okay, we're running out of time here, but we do have time for just a few more questions. Here's one. We have been using ENO as a diagnostic monitoring tool in our office. Any idea when we might see an ATS standards for this?
Again, another great question. I think, there are now reimbursement codes for doing FENO, but it still has not reached itself in the guidelines in the literature. So my guess is that there'd probably be a statement when there's the EPR4 recommendations made in the next few years.
Okay. And one last question here. One person is expressing concern about most patients coming to their ER saying their MDI isn't working, but they don't know they don't know that if they do not prime the MDI, they aren't getting any medication. Shouldn't this information be given to them by the pharmacist at the time of dispensing and not when they end up in the ER? So I guess the question is that a fairly common question?
It's a fairly common problem. And again, Jim Martin, who I've worked with in the asthma clinic, we would always make sure that when they left our clinic, if they had one, they were taught how to prime it. If we gave them a sample, we primed it for them, so there would be no chance of that. You're absolutely right. The emergency department is not the place where they should be learning this information firsthand. And that's why I think asthma educators, certified asthma educators is important, because again, physicians just don't have the time to be doing that from one step to the next, but all this is very important.
Well, Bob, I want to thank you again for a great presentation today. I ask that you turn off your microphone, and I want to remind those of you that are watching this as a live presentation today, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, then this concludes our presentation.